And we are live.
Terrific. Good evening, everybody. This is Dr. Gigi Ilbayumi. I am trying to see all the panels that are here. I just came from clinic, so forgive me. I'm a little discombobulated, but welcome to our Rodham Institute speaker series. I am the founding director of the Rodham Institute, which is dedicated to improving health equity right here in Washington, D.C. I'm proud to share with you that this weekend we had a very successful event to vaccinate members of Ward 8, residents of Ward 8. Ms. Cora Berry, who is the former First Lady of Washington, D.C., and also the founder of the Southeast Tennis and Learning Center, which really uses tennis as the hook to engage kids in education. She called me probably 6 weeks ago now and said, you know what? People in Ward 8 are dying of COVID. I'd like to host a mass vaccination event. I want to do the Johnson & Johnson vaccine because it's just one shot, makes it easier for people. I said, sure, the Rodham Institute would be happy to help you. But tell you what, given what I'm seeing in clinic and what I'm hearing from all of my colleagues and community-based partners, I said, you know, mental health and food and health literacy and re-engaging people into care is also really important. So what we did is, I think, something that I don't think has ever happened in DC. We brought together every single academic institution, Georgetown, GW, Howard. We engaged Children's, and we brought United Medical Center in. We brought the 3 Medicaid CMOs, Care First, MedStar, and AmeriHealth. And what we did is, the model that we used is that we had the 10 community-based organizations that live and reside in Ward 8 and who know the residents best were the ones that really led the registration. They called and connected people and got them registered. I would tell you what we learned, and this is really Ms. Berry's sort of her political experience. It was very much like getting out the vote. And the reason it was so important to really double back with people, a few days before our event, there was that Johnson & Johnson, there was a lot that was contaminated and they had to move that. Hundreds of people who were registered canceled. So education is a continuous process. The Rodham Institute also educated the community-based organization leadership, because they were the ones that are calling their clients. We provided free Uber services, free childcare. I mean, it was just really special. All of the people from Food and Friends to Capitol Area Food Bank provided food on that day, and 500 boxes of food. We had giveaways. We had people from Whitman Walker Health, City Block. I mean, there's so many people. I don't want to forget anybody. We're going to write this up and share this document with all of you. But I wanted to just say, hi, Dr. Cheryl. I see one of my patients there, and I just want to give a shout out to her mother who passed last year. Ms. Doby, who's actually an icon and a very important member of this African-American community. She, and I don't want to tear up, but she was really an educator, and she insisted that her daughter get a PhD, and her granddaughters, and now her great granddaughters are following in her footsteps. So thank you, Dr. Cheryl. So going back to our event, what we have now has happened is that Georgetown has invited us to replicate this. So what we want to do is we want to share this. We're going to create a toolkit and really try to scale it up, because before we get started on the topic at hand today, COVID, the variants are now in all 50 states in the District of Columbia. Yes, it's true that the current administration is doing a great job of vaccinating people, but remember, they came really behind the 8 ball. So we must be diligent, especially reaching out to younger people between 18 and 40. That's the group that we really have to reach out to. That's where I'm going to stop, because we've got such wonderful guests again this evening, and I'm going to, without further ado, welcome them. Dr. Angela Thomas is my colleague from Georgetown MedStar, and she is the PI for this wonderful grant that the Clark Foundation gave and awarded to Georgetown MedStar, Safe Babies, Safe Moms. So welcome, Dr. Thomas. Please start us off and tell us about your great work. We had a great conversation the last time, but welcome and tell us what's going on with you and with your wonderful program.
Thanks, Dr. Gigi. Thanks again for inviting me back for part 2 of a wonderful conversation about keeping moms and babies safe. So thanks for that intro on Safe Babies, Safe Moms. So it's an initiative funded by the Clark Foundation, and it is a 5-year initiative. It's primarily a clinical initiative with a strong research component, but it is geared towards addressing issues of maternal mortality and infant mortality, with a very specific focus on reducing disparities in that space. We see nationally that there are disparities specifically for Black moms and Black babies in these indicators of mortality. And it's even worse in the district. And so the Clark Foundation has put $27 million behind a $30 million initiative to address disparities in this particular space. I'm really excited because it's a complex initiative, but it's doing the work that should be done. So it is integrating very strong care delivery service lines with our women and infant services. People will know it as midwifery, obstetrics and gynecology. Also our child and adolescent psychiatry, behavioral health component, our family medicine, our community pediatrics. And then really excited because it also branches out and makes our community partners true partners and collaborators as well. Community of Hope and Mama Toto Village. And then it branches out even further in that it engages folks like the Rodham Institute and the mayor's office and so much more, other key stakeholders in the district doing amazing work in this space, all with the same goal to keep our moms and our babies safe and to address these disparities in maternal and infant mortality. So really excited about that. Many of our clinicians are connected to the work that Iana, who is also on the panel today, does with DC Next. So really, really excited about this conversation. So thank you for having me back.
Oh, of course. And, I just want to, before we introduce, is it Dr. Clarence or Miss Clarence? Forgive me. It is
Miss Clarence, but one day it will be Doctor.
Okay, all right. Well, I just wanted to say, I think, an important point, and this is something that I just want to keep saying and emphasizing over and over again. Last Saturday, we saw what could happen when all of the academic institutions and all of the clinical healthcare entities get together with the singular purpose of serving the good people of Washington, D.C. And I think it's important that we try to put our egos aside. I know that sometimes people are very competitive. Oh, it's GW, Georgetown, Howard, MedStar, whatever. But it actually benefits all of us. And most importantly, our families, our community, our patients, the citizens of the district, but also including ourselves. How good do we feel when we're working together, right? How good did it feel when I saw at the mass vaccination event, GW, Georgetown, and Howard students all sitting together interprofessionally. So you had nurses and medical students and pharmacy and dentistry. I mean, it was just really beautiful. So in this initiative, Georgetown MedStar is the lead, and we're playing a supporting role, the Rodham Institute. It may be that Howard will take the lead on something, or GW, or Children's. But I just wanted to kind of emphasize that for everybody that's listening, because truly, if we're going to make a dent on name whatever disparity, we have to work together. We do better when we work together. So without further ado, Ms. Clarence, can you join us and tell us a little bit about yourself and what your role is with this special initiative?
Wonderful. First, I want to say thank you so much, Dr. Gigi, for having me. I'm really excited to be joining the panel alongside Dr. Thomas today. My name is Iana Clarence, and I am the program manager for DC Next, which stands for DC Network for Expectant and Parenting Teams. And it is overseen by the DC Primary Care Association, but it is a 3-year grant-funded project through the Office of Population Affairs Teen Pregnancy Prevention Program. And really what we're doing is we're building a collective impact innovation network that is really created with and for teen parents living in DC. So much like you said, we don't, a lot of times we work in silos, right? And what we're really trying to do is bring all of the organizations, the community-based centers, the hospitals. We're trying to bring everyone together to make a broader impact on our teen parents. And what we're looking to do is to truly amplify the rights and the voices of our expectant and teen parents in DC, and to not only do that, but to make them a high priority for engagement, investment, and support.
Well, that's terrific. I don't think we have anybody else on the panel, do we? Am I missing somebody? I want to make sure that I'm not missing anybody else. Well, let's talk about that, Ms. Clarence. I mean, the last time Dr. Thomas spoke about the stigma of teen parents and how often, we as a society judge them and make them feel badly, like they've committed, a mortal sin. And then as such, they're really not included in certainly they can be marginalized in educational spaces. And they have special needs as teen moms or moms to be compared to, adults or women who are sort of further along in their life. So tell us a little bit about the people that you serve and what is special about your population. I mean, what makes them special and unique and resilient, but also what are some of the things that make it a special challenge for them?
Yeah, so what I'll say is 2 things. I think the one thing that makes them so unique is that I would say they are the most resilient group. I work weekly with teen parents in DC, and they are just extremely resilient. I mean, they're dealing with COVID, they're dealing with not having jobs, they're dealing with having to find childcare for their kids, if they even feel safe, with their children being in childcare. They're also trying to balance school. And despite all of that, they still have such positive attitudes. They still, even with the network, they are so engaged in building this network with us. And not only for themselves, but for other teen parents whose voices are not being heard. A lot of them, you mentioned the stigma, a lot of them are seen in a poor light just for the fact that they had a child at a young age. And for some of them, it was not a mistake, and it's always seen as, oh, it must have been a mistake. But for some of them, they're actually very happy to be parents, and they're looking for adults to truly, support them. A lot of them have been, disowned from their parents. They've been in the foster care system. They've been in the legal system, and they've been through a lot, but despite it all, they are so resilient. And I just think that's what makes them so special.
So for those of us that are either caretakers in the healthcare field or just adults in the community, I mean, what would they or you as somebody who works with them want us to know or do differently than what we're doing right now, sort of, without having the knowledge and what you just shared with us?
Right. I would say, just to be just as non-judgmental as possible, and to truly get to know them and on a personal level, get to know about their life, get to know about their family, their upbringing, and to understand that they have very complex lives, and the system as it currently stands, we don't, our organization, our network, we don't feel like there's a system in DC that's very comprehensive and collaborative, that really supports teen parents. And that's, really what we're trying to do. And so I would say, for caregivers and providers to just be more supportive, help them in finding the resources that they need, not to, like I said, not to judge them. We've heard a lot from teen parents that, they face bias, they face stigma. They may be treated, not the best way, by a different social service department. So they have a lot of stories, right? So I would say, really just to be as supportive and non-judgmental as possible.
Well, that's very helpful. I think the last time when we had part one, I shared them of Egyptian heritage, but also African culture. When a woman is pregnant, she's actually elevated. She is not supposed to ever be upset. If she tells you to jump in the lake, you're supposed to go jump in the lake. So it's interesting. And I think our society here, American society, does not elevate the mother, the child, and the family, parents in general. Now, the last time, Dr. Thomas, you had shared your own story. Can you tell us what it felt like when you were going through your journey in the earlier part of your life?
Sure. Yeah, so I did share, Dr. Gigi, that I was a teen mom as well. I had my son a month before my 17th birthday in my senior year of high school. And it was quite the journey. I would say, to some of Iana's points, I remember when I finally did decide to tell my mother, one of the first things she did was put me in counseling. And there are some amazing counselors, psychiatrists, behavioral health professionals, and it's important. But to Iana's point about not judging and not making assumptions, I felt that particular counselor in that situation made so many assumptions about me and didn't take the time to get to know my story. Why did I end up pregnant? What was that journey? And so I remember, to your point, Dr. Gigi, about the pregnant woman doesn't need to be upset. I remember being so upset and begging my mother not to have me go back, because this particular person really didn't see me. They saw what they assumed about me. And from there, I made a promise with her that I'd continue my education and do whatever she asked me to do, as long as I didn't go back. And that was our partnership. She supported. She didn't enable. So I had to get up and go to school, pregnant and sick and all. But as Iana outlined, I found a resilience in myself that I found that I could do things that I really, at that time in 96 was the time that really, I didn't see a whole lot of examples of that. And so I kind of had to forge my own path. But from there, I said, college is still an option for me. Online was not really a thing, online education. So I applied to universities that had family housing. In Michigan, I'm from Michigan, so I applied to the University of Michigan, Michigan State, Wayne State University. I could stay at home at Eastern Michigan University. I could also live in family housing. And I got into all four and decided it was best for me to go away, but not too far from mom. And since she was an alum of University of Michigan, I chose University of Michigan. And
Good choice. Go blue.
Go blue. And so my son and I moved on campus when he was 5.5 months. And I was 17, and I didn't know college any different. It forced me to be organized. It forced me to be disciplined. It forced me to be regimented. And I tell people when they ask kind of why I'm like that today, I point to me still having a space where my brain was still developing, and yet having to learn how to be regimented, disciplined, and structured. And so that was, lemonade out of lemons a little bit, in that it turned out well. And so once I kind of figured out that it was possible, and with a lot of support, a lot of people, a lot of community, a lot of faith-based and community leaders, a lot of family, a lot of friends who got past the shock of it and got past the shame and began to celebrate that a child was coming and a child was here, and support me in my journey. That really was really important and key. And so that has become my journey. I tease people all the time that my doctorate was the only degree I got that I didn't have to raise my child. And so I'm like, oh, that's a breeze. But now he's graduated from college himself. He has a bachelor's degree. And so it just really is important, the work that DC Next is doing and the heart behind how they're approaching that work, and really seeing the parents as people. And so I just love it.
So how are you, thank you for sharing that. I mean, I think, that these personal stories are really what bring life to what can seem like very dry facts or statistics. And there are human beings and stories behind every statistic. And I think it's important that people hear these directly because, I always tell the medical students or the residents that I work with, it's okay to be judgmental, but you have to be open to changing your mind. I mean, some of our professions, you have to make judgments quickly, but keep that in the bubble, but just get to let the facts lead you to change your mind. I remember actually, now that you're mentioning this, I just had a thought. I was a news editor for a high school paper in East Lansing, because that's where I lived and grew up. And we had one young woman who was pregnant, and I actually followed her for the day. Now, she was actually married. She was received very, very differently. And I was actually pleasantly surprised that everybody accommodated her. But Ms. Clarence, how are teen moms integrated into the school system? I mean, are there some best practices and some sort of exemplars that you can point to within the district?
Yes, so I do know that there is New Heights. I don't know if you guys are familiar with New Heights, but that is a program that is specifically catered towards teen parents and very supportive in breastfeeding and providing them support such as sending them diapers. And so I do know that there are some services within the DC public, school system that are for teens. But we in DC Next actually, just to give you a little bit more context, there are 3 key domains that we're focusing on, and one of them actually is school-based services. And that is actually led by Howard University. Howard University and Children's National are 2 lead partners on this project as well. And they are actually testing innovations to see really what would work best for our teen parents. What do they need? What are they telling us about, how the school system is or, is not, supporting them? And we are working to develop innovations that in turn would support, kind of fill those gaps, right? That's what we're trying to do, is fill those gaps. So I guess that's what I would kind of say there, is that there are some supports, but within our network, we're looking to build stronger support through the school system.
Well, schools, I think one of the things that the pandemic really highlighted is really the importance of schools as a place of public health, as a place of really safety and welfare for children and young people. We of course know that during the pandemic, things like domestic violence, family violence, child abuse went up because there are mental health services that happen in the school. My friend and colleague, Dr. Olga Price, who is at the School of Public Health, actually was instrumental in bringing telemental health into schools before the COVID crisis by several years. Children's National and now Howard as the leaders of doing this innovative work. I think that, there are also clinics within the schools themselves, but I think, as sort of my thinking has evolved around these issues of health equity and health disparity, I think that holistic approach is so key, looking at the educational needs, at the mental health needs, at the physical needs. And then if there are special populations, such as teen moms or disabled, kids, or kids with, special needs, they're either deaf or hearing impaired or blind, but that the core services are really addressing food, sleep, mental health, physical health, and just overall emotional well-being if it's the education space, well, then that's the space. If it's the clinic space, that's a space with a different focus. But Dr. Thomas, I know that you're also looking at sleep as a really important piece and breastfeeding. Can you talk about why that's important for child development and what your particular initiative and work is doing in that space.
Absolutely. So we have amazing clinicians in community pediatrics, behavioral health, and women and infant services that have seen in their care for patients, moms, babies, families over and over again, that immediate skin-to-skin contact at delivery, that lactation support for moms and parenting individuals, that proper sleep to avoid things like SIDS, et cetera, but also just stress mitigation for the family overall is extremely important. So those are elements that we not only weave in Safe Baby, Safe Moms, but we do it intentionally at the time periods as early as we can where it makes sense. And so we don't start lactation support at delivery. We talk about breastfeeding and the importance of it prenatally. So that we don't wait till postpartum visits to connect a family with a pediatrician. We do that early in the prenatal space. And so these relationships begin to forge between the providers along a trajectory. And so we look at 5 different time points: preconception, prenatal, delivery, postpartum, and 0 to 3 years of age, because we believe that a healthy family, healthy moms, healthy babies, and the extension of that family, dads and other social supports are important across a trajectory. A mom, once she delivers child number 1, may get pregnant with child number 2, and that cycle starts again. And so establishing true relationships with care providers and community members that family trust is extremely important. And it is that relationship that we're able to understand the true needs around things like sleep, lactation support, mental health, food insecurity, and some of those other things you brought up, Dr. Gigi. We're able to understand the needs of the family and cater to those families.
You know, one of the emerging really structural and social determinants of health that has really had a very negative impact on families during the pandemic is housing. We are actually been working with one of our staff members, Ms. Christina Williams, who's the head of the community engagement, and one of our medical students who's actually going to Columbia to do a residency, student Dr. Chinello, almost doctor. But they were working with Brooklyn Manor, which is a place which is being gentrified. There were 50 multi-generational families there. And the conditions of the house, because they really wanted to displace them so they could tear the building down of their housing, mold on the walls. They said that they would have air conditioning to the summer. Nope. We tried to actually have 2 flu clinics. Nope. They blocked that. They said that they would have internet for the kids to do their homework. Nope. And so now you have these families led by a community activist who's, I think, 83 years old. They unfortunately lost their appeal, their legal appeal. So, I mean, that's just like another layer. I mean, it's like, I can't even imagine being pregnant with in a multi-generational home in COVID, maybe with some other children that, trying to raise, and then having to find housing. I mean, is that one of the structural and social determinants of health that you're looking at?
Absolutely. It's a top one for us. And so not only are we going to screen for it, but also, especially one thing I'm really proud of in Safe Baby, Safe Moms is that we've embedded a medical legal partnership. And so this is what we call a health harming legal need, right? So there's something going on in that family's life that has a legal solution, but absent that solution, it's negatively impacting their health. Mm-hmm. And so in partnership with the Georgetown Health Justice Alliance, we've been able to embed a medical legal partnership within Safe Baby, Safe Moms that they can figure out. One of my favorite stories, not related to Safe Baby, Safe Moms, is that there was a child who was frequenting the emergency room, and they just couldn't get the asthma under control, just couldn't get it under control, just keep going to the emergency room. And one day the provider, they were about to admit the child and figured out that it was the conditions of the house. it was the conditions of the window and the AC and all those things. And one simple letter from a lawyer, the provider tried to write the letter, but the landlord ignored it. But a letter from the lawyer got it fixed and got the asthma under control. And those are the kinds of things that we're happy that we can provide under Safe Baby, Safe Moms is looking to see. And housing is a prime example of something that to have a legal fix. And my heart is broken to hear that there was a legal appeal in the case that you were talking about, Dr.
Yeah.
That breaks my heart. But
Yes.
it just outlines that if somebody's pregnant and dealing with all these issues on top of issues on top of issues, maybe their priority doesn't end up even being their health.
Exactly.
I just want to get my children educated, or I'm just trying to figure out how to keep the lights on, or I'm just trying to figure out how to get some food on the table. And I'll worry about this pregnancy a little bit later, but right now I got 3 kids
Yes.
whose shelter is in danger. And those are the kind of things that no mom should be having to worry about as they're pregnant.
Well, and then for my colleagues who are clinicians in the audience, I think that we tend to be judgmental when somebody doesn't follow up or do as we ask, whether it's medications or following, oh, you need to lose weight or this and that. And this notion that you just mentioned of competing priorities is real. I mean, there is the hierarchy of needs, and food and shelter are very high. So Ms. Clarence, in terms of the teens that you work with and serve, how, is there a special program for homeless teens or housing insecure teens?
So I'm not sure if there is a specific housing program, but I do know that we are working within the network, and housing is actually also a priority of ours. After hearing from our teens, like I said, that many of them, have been put out by parents. They have been in the foster care system. Some of them have, experienced homelessness themselves. And so we have raised that as a, priority within the network that we are targeting, and are hoping from a policy level over the next 3 years, to see some changes in.
Well, I'm just going to give a shout out to the Covenant House, which is there on Mississippi Avenue in Ward 8, because they are just amazing. I mean, they take, I think the upper limit is of people that can go there are 26 years old, but they actually allow for 2 children to come along with a person, which I think is so key. And what's so wonderful, in the first 72 hours of them checking into the Covenant House, all they focus on is getting a shower, settling in their room, eating. They don't even do any intake, because being homeless or being kicked out or disinherited or disowned or whatever is trauma enough. And people just need to kind of settle into a safe space. And what's amazing about the work that they do is they actually have a literacy program. It turns out that a lot of people who, not a lot, but some people who may be homeless don't know how to read. And so some amazing people that actually teach people how to read, and they can skip like 3 grades in 3 months. And then they have a working program to get people to get, to work and to be able to support themselves, and if they've got kids. So I think that, there are these pockets in the district that are pretty amazing. And, as somebody in the Rodham Institute, our goal is to really connect these groups, because there are so many wonderful models, but I think that they need to be upscaled. So, Ms. Clarence, if you had a magic wand, because you mentioned policy, and you wanted to improve the life and health and well-being of teen parents, what would you do in terms of policy? You could choose anything. What would be your sort of, well, you know what, not just one, let's give you 3, makes it easier.
3 things that I would want to see happen.
Yes.
So I think one thing that I would love to see happen is if we could find a better way for our school system and our healthcare system to work together. Because, it's very difficult, I think like Dr. Thomas mentioned, teen parents have a lot of competing priorities. And unfortunately, is it my, that I am going to go to school, or is my child going to, what if my child doesn't even have care? Who's going to watch my child while I'm in school? So now I can't go to school because I have to be home to watch my child. And so I think there needs to be a better system. We need a better comprehensive system where the social, the school, and the healthcare system, services and systems are speaking to each other, and we're kind of on the same page. So I think if I could have anything, it would most definitely be that we're doing a better job of talking to each other and supporting our team so that they can graduate and that they can live, fulfilling lives, I think that would be it for sure.
Mm-hmm. Well, I think that's why the Clark Foundation and what their priority areas of what they're supporting is so important. It never ceases to amaze me about the amount of money that's spent by the government in things that actually, like war and military, when actually if you invest just a fraction of that to support the health and well-being of mothers, fathers, babies, children, and put that money into education, how much would be saved, not just in terms of money, of course, but more importantly, the health and well-being and potential. I mean, when you change the trajectory of a developing fetus and a baby, that's how many years? 80, 90 years. And that, gosh, that could be the person that will discover the cure for cancer or discover the vaccine for AIDS. I mean, these are the kinds of investments, and I'm so happy to see that the Biden-Harris administration is really looking at some of these policy changes. But Dr. Thomas, I mean, we can criticize ourselves as clinicians or people who work in the healthcare space. I'd like for you to sort of speak directly to the clinicians taking care of, and I'm not going to say that we have to keep the midwives and the doulas in a separate category because we know that they don't do this. So for those of us that may be OBGYNs or pediatricians, what would you like those people to know or do differently?
Sure. So, that's a loaded question, Dr. Gigi, but I'll try my best. So I think at the heart of every clinician, they enter into medicine with the same intention to see humans have better health, to do everything they can, save lives and improve health outcomes. And I do think that the day-to-day, the policies, the administrative burdens, the pressure for RVUs, the pressure for the small 15-minute windows of time, and the burnout, the overload, and then layered on that COVID. I think all of those create distance between that original heart of why clinicians entered medicine. And sometimes you end up with clinicians who don't take the time to just remember that that's a human being, that that's somebody's mother, somebody's sister, somebody's dad, somebody's brother, and with their own life experiences. And to your point, acknowledge that you already have some judgments there, but seek to understand to see if it changes your mind, And I think when you come to the table to genuinely spend the time to understand the human that is in front of you, I think at the end of that, you can't help but give better care. And that can be easier said than done because of all of these other dynamics that are around a clinician. So, it's not this profound, recipe that I'm offering here. It's just slow down and remember that's a human in front of you with a real sphere of challenges, people who care about them, people they care about, and much more. And their experience is going to be like no other human that's been in front of you. And so taking the time to understand that is key.
Well, you touched on something. Actually, today in the Washington Post, there was a publication of the poll of the Kaiser Family Foundation, and the Post did, of healthcare workers. 62% of us have been negative, our mental health has been negatively impacted by the pandemic. So, one of the reasons that I actually started the Rodham Institute as a medical educator was seeing that bright-eyed, bushy-tailed medical student who was going into medicine for all the right reasons, and then them ending up by the end of their training, sometimes objectifying the very people on whose backs they trained. And so what I saw is sort of putting a mirror up to us as academic medical institutions is that first, we don't provide the support in the hospital for case management so that when somebody has a lot of needs, that it doesn't fall to the intern or the person on the lowest on the totem pole to deal with these very complex issues. I mean, it requires more work. That's number one. And also to see people in non-sick roles. That was one of the beauties of the vaccination event on Saturday. People went to Ward 8. It was a beautiful day. It's Ward 8 is beautiful, right? And then they saw people, families coming out and not being sick, but if your only experience with residents of Ward 8 is to see people laid up in bed or asking, that they're in distress or whatever, that changes something. But let me let you in on the secret. I've been a doctor for 35 years. And I think sometimes people are afraid that they're going to open a Pandora's box by asking those personal questions or trying to get the story. But let me tell you what I've found. If you know somebody's story, guess what? You actually save time. Because you're listening to people, and when you are listening to them, oh no, I really don't want to take this medicine, or I don't want to do this, you're really getting at what is important, how they want to be treated, what are the issues, all of that. And so, I'll sort of bring it back to the COVID vaccination, because there's been a lot of talk about, oh, people are resistant, blah, blah, blah. Well, guess what? It takes me all of 2 minutes to talk to my patients who are like, no, I'm not going to get the vaccine. And you're like, why not? And so they'll say, oh, conspiracy. I'm like, let me tell you, I got it. My parents have got it. My siblings have got it. And I would never suggest something that I wouldn't do for either myself or my family. And then, of course, we answer the questions. But this notion that being human and showing up as a human being somehow takes more time, it's the opposite. And guess what? It has actually been shown to improve the mental health of the clinicians. That's not to say that all these other things aren't crazy making, like, right, the insurance and all the other stuff. But you're bringing up such important topics. But what can, I'm going to sort of take it through and ask you, Ms.
Dr.
Clarence.
Gigi,
Yes, please, go ahead.
I wanted to just add something to what you just said just now. I wanted to put in a quick plug at Children's National. I think I mentioned I worked there for 3 years before I transferred to this position. And they have such a great curriculum. It's called the Trainee Education and Community Health and Advocacy Curriculum. And it does exactly what you just said. So we did some research on our pediatric residents and found that what you said, they don't ask the questions because they are afraid it's going to open Pandora's box, and they do not have time to answer all those questions, and they have to get to their next patient. And most of the time they do want to help, but they just don't know how. So what Children's did, and a project that I worked on with them for quite a while, was to develop a curriculum that really teaches pediatric residents how to address those different social determinants of health in a clinical setting. And it really, it puts the resident in the lives of patients so they can see what it's like to have to get on the bus and ride for an hour to get to a doctor's appointment, and while, a patient may be late. So I just wanted to put a plug in there that there is some work, going on in that area.
Oh, sure. And our own work at the Rodham Institute, one of the 3 priority areas is to educate everybody in the healthcare system. As a matter of fact, Dr. Kara Lichtenstein from Children's, they borrowed our Rodham Institute model, See the City That You Serve, which we bring all of the interns and we actually take them to United Medical Center in Ward 8 so that they can see for themselves. But thank you for sharing that. I always say that there are two groups of people that are really angels on earth, nurses and pediatricians. Because nurses, of course, and social workers and midwives and doulas, their training is much more holistic. And pediatricians, just by virtue of the fact that they have to deal with a family unit, have really been living and breathing the structural and social determinants of health before there was those terms that are now really catchy have even, kind of have been used so often. Dr. Thomas, can you tell us about the midwives and doulas? I've alluded to them a few times, but tell us about why they are so important and what their role is in ensuring better health for both babies and moms.
Yeah, I think we touched on a lot of that in this conversation, certainly in conversation number one, but just talking about this humanistic approach, this patient-centered approach, this mom-centered approach. That's exactly what the midwives and doulas do. So midwives are more on the clinical side, but not as clinical, if you would, as an obstetrician gynecologist, in that they do have the opportunity to take more time with the patient, with the mom, with the birthing individual on a journey, and really take the time to understand the social needs, the clinical needs, their wishes in terms of delivery and birthing and pain management and all of those things. It's really a person-centric model. And then the doulas are traditionally with them in the childbirth space and making sure that their wishes, their desires, and how they want the childbirth experience to be happens that way. And so they really are a support system. So the power, I think, of midwives and doulas is the human approach, but also very, very birthing individual centric, and really trying to make sure it's not about this activity of delivery, it's supporting that birthing individual as they have meet this important milestone in their life.
Somebody said to me the other day, why do they celebrate the child's birthday? That should be a celebration for the mother. I don't know if you said that, but I thought that was kind of right on.
And I know some moms who do that. Like, it's my birthday. Thank you very much.
That's right. But I think one thing that we mentioned in part one of our discussion was that actually midwives have better outcomes. How about that? So I've had the pleasure of visiting the Community of Hope's Developing Family Center, which is completely midwife run with physician backup, because of course there's a role for physicians, especially in, God forbid, sort of complicated births. But oh my God, it was such an impressive space, so impressive to see families being taken care of, to see the space being so welcoming and not the stark space, but they're actually, pillows and artwork, and there can be like Monopoly games for the family to play, the jacuzzi where the mom can give birth if she chooses. And of course, all of those other important services for the mental and physical well-being of both the baby and the mom, and then the childcare. I mean, that was it's wonderful. So that's great. But so I'd like to know a little bit from you, Dr. Thomas, in terms of this initiative, the Safe Babies, Safe Moms. I mean, take us sort of from beginning to end. What is sort of the ultimate final goal?
Sure. The ultimate final goal, desired state, is to decrease maternal and infant mortality in the district and eliminate the disparities in that space. And so we do that, as I mentioned, with the 5 different time points, with the integrated care delivery model, with our service lines, as well as our community partners. But just giving you a little bit more detail about each of those time points, we screen for the social determinants of health at each of those time points, behavioral health needs at each of those time points. And then we also have care navigation throughout the process. I have the luxury, if something's going on with my healthcare, or someone who I love healthcare, of being able to pick up the phone to you, Dr. Gigi, if I needed to say, hey, can you help me out? But a lot of people don't have that. Navigating a complex, very fragmented healthcare system is very challenging when you have these competing priorities that we talked about. So care navigation is super important for us. we also want to make sure that each of the families, moms, babies that we're caring for receive services that they need. So identifying in the preconception phase that if a woman were to get pregnant right now, she'd be at high risk for an adverse maternal or infant outcome. Women who have uncontrollable diabetes or substance abuse issues, those kind of things, and make sure we address those. And as I mentioned in the prenatal space, making connections and education early in that space. In delivery, there are some things like pain management that we want to address, skin-to-skin contact, reducing cesarean rates for first births when they don't have to be warranted. So in all cases, there are cases where they're warranted. And then really making sure that transition from delivery to the home is effective, into pediatric care is effective, and then transitioning to more holistic family care and making sure the child meets developmental outcomes and milestones, et cetera. And so we also integrate a research component with that. So it's a clinical initiative for sure, but our goal is to really not just move the needle in the district, not just move the needle for the moms and babies and families that we serve, but to contribute to the field so that people can learn from what we've done. And so that's why the research component is super important. We want to be able to leverage our data of these different payment models that may not be supported fully by insurance at the moment, that they work. And so maybe that will change what's covered under insurance. So there's a health economics component. We want to understand what factors, community factors, organizational factors, provider factors, you name it, work, promote healthcare, health outcomes, positive health outcomes. And what are some barriers and challenges? And being able to tell other people what those are so that when they try to do something similar, they can be prepared for them and understand the context of why things worked or didn't work. So that's implementation science. One big thing besides data science and all the nerdy stuff we do with data, one big thing I do want to really highlight is the health equity piece. And so it's really important for us, if we want to move the needle on disparities, that yes, because of structural racism, we see populations that are more at risk for poverty and education and all of those things. But here's the fact of the matter, and we talked about it last time, Dr. Gigi, even controlling for all of that. So let's just say all of that's equal. Education and finances, all of that. We still see disparities. Now, at the heart of that is structural racism. And it goes back to your point, Dr. Gigi, of a woman shouldn't be upset, a woman should be relaxing in this space. But we live in a country where you have to be worried about being treated a certain way because you look a certain way. That doesn't allow that woman to relax every day.
Exhale. I mean, I know I'm just thinking about sort of the George Floyd trial that's going on. I mean, truly, I cannot watch it. The most that I can do is read about it. And, that is the part that is not often appreciated, the post-traumatic slave disorder, the trauma and the PTSD that people have to live. And what does that do to a developing fetus, to a developing brain, to a mother, to a father? Because in a minute, Ms. Clarence, I'm going to come back to you because we haven't mentioned fathers, and they're very important. We haven't mentioned how their health affects the quality of their sperm, not to mention the quality of their interaction with the babies and the mother. That is, if it's a heterosexual couple. We also know that there are same-sex couples, women, or even trans couples, where the issues are actually even more sort of compounded, if you will. I'm sorry to have interrupted you, Dr. Thomas.
No. So it's exactly those issues that we want to really understand and tackle. And so there are things that, obviously those issues that are an issue for our country bleeds into our healthcare system.
Yes.
And the training and the interactions with people and so much. And moms and birthing individuals come into the healthcare system worried about those things. Will I be treated a certain way? Will my voice be heard? And so we want to be intentional about training our workforce to understand these issues, understand how to treat people, how to understand. You may have some judgments, but how to ask questions and kind of get beyond that. We all have them, to understand that human perspective, but also understand how people are coming to care. The
Exactly.
mindset of that post-traumatic stress, of trauma, that day to day having to worry about, will this person receive me as a human, or do they see my skin color? Do they see my gender? Do they see my sexuality, and so much more? And
Mhm.
so we want to be super intentional about that, not a one and done by any stretch
Exactly.
of imagination, because it's an ongoing conversation, it's ongoing training, and it didn't happen overnight. And so it won't be fixed overnight. And so we're committed to making sure that that remains a really key element to our initiative. And to get at that, we've got to hear from the families. We've got to hear from the
Yes,
mothers. We got to hear from the birthing individuals about their experiences.
exactly.
We're doing an amazing job all day long, but if that doesn't translate into their experiences, we still got a poor health outcome.
Well, and that's why I love the work that Miss Clarence is doing, is that the teen's voice is really at the heart of it. But, let's talk a little bit about teen fathers, or as we said, same sex or trans kids. Can you illuminate us and maybe educate us about any blind spots or myths or misconceptions that we have?
Yes, absolutely. So what I will say, just a few things. In the first year of building this network, we have actually had a very difficult time recruiting teen fathers. Majority of the teens that we're working with are teen moms. And that has been a gap of ours, and we have been very persistent in trying to find some teen fathers to hear from, and actually are still in that process. So if anyone listening, or even if you guys know of programs, that support teen fathers that could potentially support us in building this work that we're doing, that would be great. But one thing that I will say that we've heard from teen moms is that a lot of times there's this stigma that fathers are not involved, or, that it's just the mom and that the father is absent. And that is not true. We've heard that from our teen parents, that the fathers, they are involved and they have good relationships and, those things. And so I think that is a very big stigma, especially within the Black community. And I think we are working to try to dismantle that, right? That is very big for us.
Well, we've got a couple of minutes left, and I would be remiss if I didn't mention my good friend, Dr. Javaka Moore, who is an OBGYN, Howard trained actually, and he has an office in the United Medical Center office building. And what I've been struck about his practice is that he only has a 3% C-section rate, and also has, works with midwives and doulas. But what's great is that I see a lot of fathers that come with their, the expectant moms and families. And exactly what you're saying, Ms. Clarence, there's a lot of mythology around Black fathers in particular. But I think it's also about the welcoming space. I think that there is so much judgment, right? Where Black men are vilified in general, but particularly around teen pregnancy, right? That we don't make that space to be welcoming. So whatever space that we're in, to your point, Dr. Thomas, it is so important to be intentional, to think about how we are presenting ourselves, whether we're clinicians or working in a community-based space or whatever. And to really, to your point, Ms. Clarence, is the voice of the teen, or the teen mom to be, or adult mom to be, or whomever, and of course the parents to be, family, really has to be at the core, so that we can really know what the best practices are. So with that, I want to see if Dr. Thomas, you have any final words for the group?
No final words, just a thank you to you, Dr. Gigi, and the Rodham Institute for the opportunity and just engaging in such important conversations. I know you have important conversations on many, many topics. So thank you for inviting me to be part of 2 conversations on this particular topic. Wow. Wonderful work, and continued prayers and well wishes for the COVID vaccination efforts. Amazing.
Thank you. Thank you. Thank you. And Ms. Clarence, any parting thoughts?
I think I would just echo Dr. Thomas in saying, thank you so much for providing this opportunity, and even more specifically, providing a platform for us to have this conversation, especially for our teen parents. I think this is just one of many, sessions that we'll have in the next few years to have these conversations. But I think this is really where it starts, right? We have to get the conversations going, to really to gear up interest and to really make a greater impact. So I just want to thank you guys for raising this and bringing some awareness to this issue.
Sure. And maybe the next time we'll have teen parents, both women and men, as part of the panel, so we can hear directly from them. But let me tell you something, ladies. When I think about all the issues and challenges that we have in the world, I look at both of you and I know that we're going to be okay. Because truly, you are doing such important work. You're so gracious. You're so open, and you've shared your time with us today. So we're very appreciative. And before I sign off, I'd like to just thank our wonderful staff who has been super busy with everything that we're doing. Ms. Ashanti Carter is the program manager, and she is the person that helps put these wonderful webinars together. She runs the newsletter. She does so much stuff. Ms. Christina Williams is the director of our community engagement. And as I mentioned her, the Brooklyn Manor, the vaccination efforts that we're doing. And Ms. Tracy Bass, who's the director of the Doctors of Tomorrow program, the University of Michigan, that we're duplicating, right? And we just, this weekend, we met two African-American male class presidents from Georgetown that are going to be joining us in the Doctors of Tomorrow to be the people who will actually work with our kids. And I see email links about the programs for expectant moms that were mentioned. Sure. Can you mention them really quickly, or maybe post them?
Sure, I can post them. I will post a link in the chat real quick.
Great. So we're just delighted that you all have joined us, and please stay tuned. Oh, while you're doing that, Dr. Thomas, we have a date for our summit that was canceled last year because of COVID. It was scheduled for March 12th. So now this is our 7th annual, because we missed one, and it's about mental health. And I'm so excited because we're going to have special populations, looking at, LGBTQ health, young people's mental health, people from the disabled community's mental health, as well as just understanding what community-based organizations are doing, how COVID has impacted our mental health, which it has for sure. So please, if you're not part of our listserv, please sign up for our listserv, because then you'll get an invitation to the May 6th event. And of course, Hillary Clinton is going to be there. We're trying to see if we can get Bill and Chelsea to join us too. So, all right, with that, we wish you a good evening, and thanks for joining us. And again, thank you, Dr. Thomas. Thank you, Ms. Clarence. See you next time.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Bye.